Welcome to Pediatric Perioperative Nursing. This is Tracy Blair, and I will be talking about all the different areas that we have within our perioperative setting, all the different roles, and all the different things you would see if you were to work in this environment. In pediatrics, we're concerned about different age levels and developmental levels that they exhibit what is the norm and what is not. If you click on this chart, you will then be directed to Bright Futures. This is a great website that goes over all of the normal development for a child at any age. And from those, you can then see whether or not a child is progressing along the way they should be or if they are delayed. The definition of a perioperative nurse is a nurse that works with patients who are having operative or other invasive procedures. Perioperative nurses work closely with surgeons, anesthesiologists, nurse anesthetists, surgical technicians, and nurse practitioners. They perform preoperative, intraoperative, and postoperative care primarily in the operating room area. Perioperative nursing offers some of the most exciting, demanding, and well-paid work in the nursing world. Also known as operating room nurses or OR nurses, perioperative nurses are registered nurses who work in the hospital surgical departments, day surgery units, also called ambulatory surgery units, clinics, and physician offices. They help plan, implement, and evaluate treatment of the surgical patient and may work closely with the patient, family members, and other healthcare professionals. In day surgery, the pre-op nurse is the nurse that determines whether the child is ready for surgery. They will do an evaluation for an illness. They will make sure there's an informed consent. They will make sure that the family and child is ready before they come back to the OR. Some of the assessments that they will perform will be the patient's history, language or culture, history of present illness, allergies, especially latex, medications, bleeding history, recent illness or exposures, anesthesia history. Adolescents that are females will need to have a HCG test, sickle cell history, and any family history that would have a severe reaction to anesthesia would be noted, and things would be done differently in the OR. The other thing I would like you to do is click on the center picture to see what happens during surgery, and click on the right picture to see how you get checked into day surgery. Sometimes the day surgery area is called the holding room. It's the room that the parents are in before they go back to surgery. The biggest thing about the consent is they need to review to make sure that the family is aware of all the risks, benefits, and alternatives that there are for surgery. If they do understand all of those, then they can have the consent signed by them and the nurse or them and the doctor. In day surgery, the pre-op nurse will also make sure that the height and weight is done accurately. They will get a set of vitals and do a head-to-toe assessment. They may give a pre-med called Versed to help make the patient relax before going back to surgery. All the while, they are documenting an epic. They also will help with restocking rooms with supplies, turnover, and setting up the bed space for the next patient coming in. They also help with handoffs when giving information to the operating room. If you click on the picture below, you can see some of the important details you would need in order to give a handoff. As we move into the operating room, there will be a different nurse taking care of the patient. This nurse is called a circulator. We will get into more detail about that role as we move on through this area. Aseptic technique is very important in the operating room. There are several principles that we follow for aseptic technique. One is that the patient is in the center of the sterile field. 2, only sterile items are used within a sterile field. 3, sterile persons are gowned and gloved. 4, tables are sterile only at table level. 5, sterile persons touch only sterile items or areas. Unsterile persons touch only unsterile items or areas. 6, Unsterile persons avoid reaching over sterile field. Sterile personnel avoid leaning over unsterile areas. 7. Edges of anything that enclose sterile continents are considered unsterile. Sterile field is created as close as possible to the time of use. 9. Sterile areas are continuously kept in view. 10. Sterile persons keep well within the sterile field. 11. Unsterile persons avoid sterile areas. 12. Deconstruction of integrity of microbial barriers result in contamination. 13. Microorganisms must be kept to irreducible minimum. 14. Movement of air current within and around the sterile field must be minimal to avoid contamination. And lastly, when in doubt regarding an item's sterility, consider it unsterile. Surgical attire and traffic patterns are very important in the operating room. We have 3 classifications that we use in order to identify what to wear. Unrestricted would be everyday clothes. Semi-restricted would mean that you would have scrubs, hat, and shoe covers. Restricted would be hat, scrubs, shoe covers, eye protection, and a mask. Traffic patterns are always watched when we are in the operating room so that we do not pull in organisms into the room. So usually the door to come in and out is in the core of the operating room area. Clicking on the picture of the people scrubbing will have you watch a video of those areas within Children's Hospital of Wisconsin. Hand washing is definitely something that we do excessively in the operating room area. Usually our surgical scrub is for 5 minutes. Isolation procedures that are in place in the inpatient world also carry over to the operating room. So if a patient is in isolation in the inpatient world, they would be in isolation in the operating room area also. The surgical team consists of many individuals: surgeon, anesthesiologist, circulating nurse, surgical tech. Operative services assistants at children are our transporters and also our environmental people. Residents, students, sterile processing department, which is the department that sterilizes all of our equipment, and anesthesia technicians, which help set up rooms and help the anesthesiologists with intubations. Anesthesiologists are key in our department. They are the ones that put the child off to sleep and also keep them comfortable during surgery. Each child or adult will go through 4 stages of anesthesia. The first stage is the beginning administration of gas or drug, which is loss of consciousness. The second leads into loss of consciousness and relaxation. This period of time is important not to aggravate the patient because they could have a laryngospasm, which we will talk about later. The third stage is the anesthesia, that is the stage of relaxation. They'll have loss of reflexes, depression of vital functions. So this is the time frame, the level where they will do the surgery. 4th stage of anesthesia is one we do not want to get into because you'll get vital function organs that are depressed and not working. It's a danger stage, and we do not want to get into stage 4. If you click on the baby picture to the right, you can then watch a nice video about anesthesia and how it works. The circulator's role is very vital within the operative field. They are the ones that anticipate the needed supplies appropriate for all the cases that they are doing throughout the day. They take and record the sponge and needle count and instrument count before the surgery is started. They receive and prepare any specimens that are coming off the operative field. They maintain asepsis, order, and cleanliness in the room. They help with anything the surgeon or anesthesiologist would need. They will make sure that they document all their activity within the room, which would include positioning prepping, getting the equipment ready for the surgery, and document this all in their electronic health record. They will then, after the surgery is complete, make sure that the dressing is dry and intact. They will accompany the patient to recovery room and give a handoff to the recovery room nurse. At the end of the case, they will always do a final count with the sponges, needles, and instruments to assure that nothing has been left behind. Also, before the surgery has started and at the end, they will do a timeout to assure that everything is correct. We will be talking more about timeouts later. Within the operating room, there are many different things that will happen due to the effects of medications that the anesthesiologist is giving. If you click on the picture to the right, you will see a number of different medications that we give in the operating room. Please take a moment to review that content. As mentioned before, the circulator is also included in the timeouts that are done in the operating room. Timeouts weren't in existence 20 years ago. The World Health Organization noted that this was something that would be important to reduce the chance of errors being made. When the ER show showed an episode of a timeout being used, many doctors and nurses watching that show then said to their leadership, "Why don't we have this?" So because of this episode of ER, timeouts were implemented all across the United States. Please click on the picture to watch that show. Positioning is a finely honed art of moving and securing human anatomy into place, allowing for the best exposure of the surgical site and the least compromise in both physiological functions and mechanical stresses in joints and other body parts. When you're doing a head-to-toe assessment of positioning, you want to include the head, neck, cervical spine supporting in a straight line, scalp, head, and face protected from hairpins, beads, tight anesthesia mask or straps, or other sources of uneven or damaged pressure. Eyes and ears are protected from traumatic pressure, objects, and solutions. The chest and torso is kept in physiological position so that adequate full bilateral respiratory exchange and expansion can take place. The breast and female are protected from excessive pressure. Arms are in physiological positions adequately supported, not to exceed 90% extension at the shoulder, inflection or slight extension, upper arm not hanging over the edge or rubbing on metal parts of the table. Elbow areas are protected, hands are free from pressure with fingers in a slight flexation or neutral extension. Palms are up on the arm board whenever possible, palms towards the body when the arms are at the side. Genitals are free from trauma, pressure, or rubbing. Assure that solutions do not pool in the genital area. The back is in physiological position with supine in straight line. Thighs and legs are straight lined in flexible position. No pressure to the iliac crest, greater trochanters, area behind the back of the knees, peritoneal nerve, and lateral aspects of the knees or to the patella. Heels, ankles, toes are free from pressure or rubbing trauma. A safety belt might be placed over the patient. Blanket or towel placed between the strap and the patient's body to prevent maceration, and other straps or positioning devices placed only over padded body parts. Ankles and feet should be padded before the stirrup straps are applied. If you click on the picture, you can see a cheat sheet for different positions within the operating room. Draping is a very important step within our OR suite. The surgical tech will hand the drapes to the surgeon, and the surgeon will, with towels, drape off the incision site. Then they will put the other drapes around that area. The drapes that are given to the surgeon are waterproof, and they are also manipulated in the least amount of ways to assure sterility. If there is any type of strike-through, which would be water that has gone through the drape, it is considered contaminated and new draping should be put into place. Thermoregulation and documentation are important in the operating room. Many times we have to use other measures to keep a patient warm within the operating room. Heat lamps or bear huggers are one option. Turning up the room's temperature is another option. We want to make sure that the tissue is perfusing nicely by keeping the patient well within their core temperature. Documentation is another thing that is important to assure that we are making note of everything that we are doing within the OR suite. In surgery, we have to maintain hemostasis and wound closures. With this, we will use suture in order to provide this closure. If you click on the picture of the surgical face, it will link you to a document with suture. There are videos within that document that you can watch that shows you how suture is made and how we use it. The handling of specimens occurs from the OR field to the circulator, and then the specimen is sent down to lab. Wound classifications are a way to identify what is the expected infection rate of a child. If it is a clean wound classification, the likelihood would be 1 to 5%. Clean contaminated would be 8 to 11%. Contaminated would be 15 to 20%. And dirty, you have a chance of an infection rate at 25%. The Sterile Processing Department, also known as Central Sterile Services Department, is an area in the hospital where cleaning and sterilization of devices used in the medical procedures takes place. The processes an instrument goes through in the Sterile Processing Department depends on its use, material construction, and other factors. Typically, an instrument coming from the operating room arrives at the decontaminated area to be manually cleaned, then placed in the ultrasonic cleaner or sonic irrigator before being placed in the washer or disinfector. Next, the instrument would be transported to the prep and pack area to be prepared for sterilization. It will then be sterilized through one of the many types of sterilization processes. Once sterilized, the equipment will either be sent to the procedure room to be used again or into sterile storage until it is needed again for the procedure. Sterile Processing Department technicians are required to wear personal protective equipment as a safety precaution to prevent exposure to potentially infectious bacteria. There are many common breaks in sterile technique that could occur. If you click on the picture to the right, there is a good article that goes over this content. There are also emergency situations that happen in the operating room. Laryngospasm is something that happens in the second phase of anesthesia. Click on the link to see what a laryngospasm is. Another thing we have to worry about is when a person has an allergic reaction to the anesthesia medicine. That's called hypothermia. If you click on the link below, you will be able to view a PowerPoint on malignant hypothermia. Other things to worry about are fires in the operating room, medication reactions, radiological exposures, and laser and hazardous materials. Once the patient is done with surgery, they will wake up and move into the recovery room. The nurse in the recovery room will then have to have knowledge of pathophysiology and body's response to surgery and anesthesia. She will make a total body assessment along with documenting those assessments. If anything is abnormal, she would then report that to the surgeon or anesthesiologist. A recovery room nurse is a nurse that usually has extensive experience as a nurse and may have ICU experience. If you click on the picture to the right, you will then be able to view a video of a recovery room nurse and her role within that area. In the recovery room, the nurse will then make an assessment of the lungs, assuring that there is no problem with the patient's breathing. She will then move on to assessing their pain and assuring that that is under control by administering any pain medications that the patient may need. She will then assure that the IV is functioning properly and they are receiving the fluids that they need after surgery. This is also usually the way that the medications are given to the patient. Once she has gotten those three things under control, she will then move into looking at the surgical site and assuring that the dressing is dry and intact and that there is no excessive bleeding that is occurring. If the surgery is done on a particular extremity, she may want to assure that there is perfusion within that extremity and also elevating that area so that there is less edema present that may cause additional pain to that patient. Another thing that she is monitoring is the temperature of the patient. Many times you have to make sure that the patient is not experiencing rigors instead of temperature problems. Sometimes rigors occur after surgery. It seems to be a reaction to the anesthesia medicine. Rigors can be controlled by giving a little bit of Demerol. Again, if you review the medication sheet that was in the presentation prior, you will see different medications that we give to help with problems that you may experience in the recovery room. Another med that is given a lot is Valium for muscle spasms. This helps the muscles to relax so that the patient isn't in additional pain. The last stage that the patient goes into is phase 2, or the inpatient unit. From there, a handoff again will be performed. You can go back to the first slides that go over the handoff, or click on the picture below and you can then review the handoff sheet again. Another thing that I added was a blog that talks about confidence. When you are a new nurse, it's hard to be confident. And if you listen to the blog, you will get some good ideas of how you can be confident in your assessment skills as a new nurse. Finally, if you'd like to get more detail about working in the operating room, you can visit my website. On the website, I have several different tabs that you can click on to see different areas of the operating room. Under the useful link tabs, there are many different sites that you can visit to see actual surgeries being performed. On the case study tab, you can go over different cases that could be seen in the pediatric world. Many of my post-conferences that I give with my students are located under the post-conference tab. If you click on the picture on this slide, you can actually see the orientation packet that I put together that has a lot of the details within this PowerPoint in it. It is also located on the website too. Well, I know if you've clicked on every picture I told you to click and you've reviewed all of the sheets that I told you to review, you've probably gone through a good 2 hours worth of learning on the surgical area field. If you have any other questions or concerns that you have about this presentation, feel free to email me at tblair@chw.org. That's my work email, and I would reply to it right away. Thanks so much for listening. I hope you enjoyed your surgical experience.